I'd like to welcome you to this session of the Center for Podiatric Education. And this week we're going to discuss a topic that I believe concerns many of us, and that's the subject of failed bunion surgery. I don't think there is a podiatric surgeon who has not had the occasion to look at a patient in whom they felt they had provided adequate evaluation and assessment for the performance of a bunion procedure, and yet had, unfortunately, a patient that was experiencing less than optimal income. Just this week, I saw a patient with complex regional pain syndrome who's under pain management, and this followed the performance of a Lapidus procedure by a local foot and ankle orthopedic surgeon. Certainly, I would consider this a failed procedure. Worse than that was the fact that the deformity did not appear to have been adequately corrected, and either there was a failure to obtain adequate correction initially or the patient sustained a recurrence. All of us see patients who come to us from other practitioners who underwent a failed bunion procedure. And I think it's important to recognize that there is no perfect bunion procedure. There is no perfect way to analyze patients for their candidacy for various bunion procedures, period. And the fact that a patient has a failed bunion procedure does not suggest malpractice. There are some procedures that simply fail. And if we look at literature, we see that all procedures, whether they're distal metaphyseal procedures, diaphyseal procedures, proximal metaphyseal procedures, fusion procedures, all procedures have some published rate of failure. We don't see procedures published that have 100% success. And it's important to recognize that and let patients know that indeed we will do the best job we can, but that failure can occur. And it's important for us not to be rapidly judgmental on the work of others when they present to our office with a less than optimal result following bunion surgery. You try to do the best you can with each patient. My old professor, Dr. James Ganley, used to say, nobody wants bad results. And he used to have a nice kind of a slide when Dr. Ganley would appear on these different panels in the old days of the Hershey seminar, and you'd have the most famous foot surgeons, both podiatry and orthopedics, up on the stage, and they'd be advancing their newest ideas and their newest procedures and claiming all these miraculous results and that they had found the final perfect bunion procedure. Dr. Ganley would get up, and his first slide always was the same. It said, "How many bad results can you afford to have limping about your town?" So you try to make the best judgment you can. We try not to be overly critical of those who have had failed procedures. Can there be negligence? Of course there can, but generally we know these procedures can result in sequelae that are less than satisfactory. I'm going to address this first session on the Austin procedure, although we will have subsequent discussions of other bunionectomy procedures. The Austin has become very, very popular in both orthopedics and podiatry. Some will refer to this as a chevron osteotomy. Why is it so popular? Well, it's technically friendly. I think most individuals can be trained to do an adequate distal metaphyseal osteotomy. It is fixation friendly. It is amenable to no fixation, simple fixation, screw fixation. Avascular necrosis is extremely unusual. When this procedure was first introduced by Dale Austin, it was condemned by the foot and ankle orthopedic community, who felt that you were osteotomizing the metatarsal distally. This would undoubtedly result in a very high incidence of avascular necrosis. We know that not to be the case. It has been described in the literature for both use in geriatric patients as well as use in pediatric patients. The osteotomy configuration makes it inherently stable. We know there is less risk of transfer metatarsalgia with distal metaphyseal osteotomies of the Austin type than there is with certain other osteotomies. But you want to get it right if you can. Dr. Ganley used to say that nobody likes to go back to the operating room. If you're lucky, you'll get a second chance from that patient, and if you get a second chance, you had better think it out and make that revision surgery work, because the chances are excellent you're not going to get a third shot. This has always been one of my favorite textbooks. This was published in 1965 by Armand Kalikian. Many younger doctors, I'm sure, have never heard of or seen this textbook. It's a wonderful compilation of all of the bunion procedures that were documented, wonderful historical text, and it really documents all thinking and procedures on bunion surgery up to 1965. And that's the textbook Hallux Valgus and Allied Deformities of the Forefoot and Metatarsalgia. Just a wonderful compilation of philosophy, thinking, and available procedures. Now, the reason I bring this up is that if we look at the chapter on complications back in 1965, so we're going back over 50 years, well, we could have vascular complications, we could have wound healing complications such as skin slough, we can have infections from hematoma, infected bursitis, we may have necrotic skin flaps, we may have reactions to implanted materials, joint stiffness, what we would now refer to as arthrofibrosis. We may see weakening of purchasing of the great toe. We may have recurrence of the deformity. We may have reversal of the deformity, meaning hallux varus. We may have metatarsalgia due to transfer of weight from the first metatarsal to the adjacent second metatarsals. And looking at the procedures available at that time, Kalikian talked about decapitation of the first metatarsal, meaning removal of a part of the first metatarsal, dorsal tilting, and in particular discussed metatarsalgia following the Keller procedure, which again in the 60s remained quite popular. He noted that one can have stress fractures of the lateral metatarsals, again from weight transfer, and then flailness of the great toe, hyperextension of the great toe, hammering of the great toe, and alteration of gait. Now, the reason I show this list is simple. Here we are, as of recording this, we're in 2018, and the complication list has really not changed. So with all our greater understanding of biomechanics, with all our improved fixation devices, with all our improved technology for performing osteotomies, the bottom line is we still see the same complications today as we did back in 1965. Bunion surgery always works for patients unless it doesn't work. I had a fellow in yesterday in the office with I was seeing from Morton's Neuroma. Fortunately, his symptoms resolved, and his wife wanted to know why we couldn't go ahead and fix his bunions. And indeed, he had very large, prominent bunions and had a very large hallux valgus deformity. And he did have an impressive deformity of both feet. And I looked at him, I said, listen, you're gainfully employed full-time. You have no symptoms associated with your bunion. You have no restriction in activity level. You're not having to modify your shoe wear. You're having no symptoms. So yes, you have a bunion and a hallux valgus, but you're functioning fine with this. And unless you wanted to make some existential argument that somehow the hallux valgus and bunion was responsible for his neuroma, which had responded nicely to topical therapy and to wider shoes and with the use of an orthotic, I see no benefit to performing bunion surgery. But I did assure him that if he were to go around town and see enough foot and ankle surgeons, undoubtedly the majority would recommend surgical intervention. So there are complications and failures. And again, as Dr. Ganley used to point out to us, if someone is functioning at 90% or 95%, are you really going to get them to 100% with a bunion operation? Now, if a person comes in and they're functioning at 60% or 70%, but they're having some significant signs or symptoms associated with that deformity, then the risks of surgery, I think, are probably justified in most circumstances, but not, in my opinion, for an asymptomatic bunion. So why do bunions fail? Well, sometimes there's patient factors, there are surgeon factors, there can be deformity factors. I mean, some bunions are just going to be difficult to correct and maintain corrected. A classic example would be the patient that has ligamentous laxity, whether it's Ehlers-Danlos or some variation of that, or just general ligamentous laxity. The patient that has a significant metatarsus adductus or medial column adductus. The person with a severe flexible flat foot deformity. And then sometimes we just look and say, I don't know what the hell happened. I thought I did the right procedure. I thought my judgment was correct. But unfortunately, the patient has a recurrence of that deformity. Again, it's very easy to look back in hindsight and be critical of the decision that's made by other practitioners when there is some complication from a bunion. But we all get these problems. We have no perfect bunion procedure, and we have no perfect criteria. So what does the patient want? Well, we have to think about it from their point of view. My friend Marty Pressman likes to say, patients look down and they want to see straight. That's what they want to see. They want to see the big toe straight, and they just don't want to see a bump. Steve Smith used to say, people want two things out of a bunion surgery. They want it to look good and they want it to feel good. And they don't care how they got there. In other words, I've yet to have a patient look at me and say, I'm very pleased with the cosmetic result. I'm pleased with the range of motion. I'm pleased with the improvement. But you performed a Cheater Aiken. I'm looking at that x-ray and you didn't reduce the proximal articular set angle. That's not fair, Dr. Jacobs. All patients care about really is that it look and feel good, and they're not going to be overly analytical about your judgment in terms of procedure selection or fixation selection, as long as there's a successful outcome. So they want no bunion, they want no bump, they want no scar. The patient wants good motion, they don't want to have any pain, and again, as my friends have said, they want a corrected result. I think one of the most important causes of failure in many bunion procedures is when you get down and actually talk to the patient. So when they get done criticizing their former doctor and how they didn't do this and they didn't do that, and their sister or brother or someone else told them that the procedure wasn't done correctly, frequently this would be an actual subsequent treating healthcare provider who implied or suggested poor care. But when you really get down to it, patients sometimes aren't quick to tell you about their non-adherence, that they were not compliant. And I really believe in reviewing malpractice cases over the years and looking at charts that one of the most common causes of bunion surgery failure is the patient's failure to adhere to the recommended protocol by their subsequent treating doctor. And I think this is widely unrecognized, and the complications and sequelae that result from non-adherence can go from trivial to catastrophic. For example, the patient may have been given a prescription for various medications, topical or oral, which they failed to adhere to. Many times the patients will acknowledge that they failed to offload the foot to protect the foot as recommended. We oftentimes have patients who smoke and fail to discontinue smoking. Well, that's fine so long as the patient is willing to accept the responsibility for the potential effects of that smoking on soft tissue and bone healing. It may be a failure to have controlled their diabetes or other metabolic or endocrine disorders. Perhaps it's a failure to adhere to recommended DVT prophylaxis. I mean, I have patients who frequently will not pay for drugs such as Pradaxa or Xarelto or Eliquis. They say, well, I didn't get it because it was just too expensive. But it's not as though they call your office and tell you, I'm not going to take this, so that you have the opportunity to prescribe a less expensive medication, perhaps aspirin or warfarin or Coumadin if you think that's appropriate, whatever. They just show up 2 weeks, 3 weeks after surgery, and you find out after the fact they've not been adhering to their DVT prophylaxis. You know, smoking is a perfect example. This was a study published by Larry Fallett and his residency staff up in Michigan, and looking that if you, for example, look at smokers, We know that they take longer to heal an Austen bunionectomy. Even secondhand smokers have increased healing times for delayed healing. Looking at smoking, as we've discussed in a previous presentation here at the Center for Podiatric Education, we know that even non-smokers can have a higher risk of complications with secondhand smoke, and that ex-smokers still have a higher risk of problems such as a higher infection rate compared to people who never smoked at all. We have decreased vascular flow in many of these patients and so forth. So smoking can be problematic. There are also surgeon factors, no question about it. So we want to select our patients appropriately, and we know that certain patients may be at increased risk for complications and sequelae. We want to do the best we can to select appropriate procedures. We want to use our best surgical technique. One of the things I always tell the residents is that you really should obtain x-rays in the operating room and save them for the medical record. I have a former friend who is a revisional spine surgeon, and I asked him one day, I said, don't you worry about the surgery you do? I mean, you're working on a lot of overweight patients who are smokers, have all kinds of medical problems. They've had multi-level fusions which have failed to go on to union. You're in that operating room for hours and hours revising surgeries that are known to have some substantial risk of a non-union and complications. And he said, Alan, he said, I can't promise a patient will heal, but what I can promise is when they leave that operating room, their x-rays will look good. So you want to make sure that you employ good surgical technique and that you verify that with intraoperative x-rays saved for the medical record. I mean, you know, the worst thing I think people do is take x-rays in the post-anesthesia unit, because now you've probably left the hospital, and what are you going to do about it if there's not optimal positioning, optimal reduction, if there's optimal fixation, positioning, and so forth. The patient's already out of the operating room. The time to fix things is while they're in that operating room. You want to utilize effective fixation, and you certainly want to use careful postoperative management protocols. Now, with all that said, we're not going to prevent some bunion failures, but what we can say, we likely will improve the incidence of good outcomes. We also have to recognize that some procedures fail in some patients, so that we have known potential complications unique to the Austen procedure, and this does not imply negligence in and of itself. People can develop arthrofibrosis, they can develop sesamoid pain, they can develop transfer metatarsalgia, they can get to later non-unions, they can develop malalignment. These things can happen. So there are known potential complications and sequelae. Sequelae meaning things that just happen after a procedure. We have general surgical complications that can occur, such as infection. And oftentimes the patient is disappointed, and the problem is not really a major sequela or complication. It's that the patient misunderstood the goals and objectives of these procedures. And as Dr. Ganley again used to point out, it's important to discuss the concept of limited results, what we can accomplish and what we cannot accomplish. And generally the goal of a bunion surgery should be to improve the ability to stand and walk and to allow better shoe selection. But we shouldn't promise patients a perfect result, that they're going to have a cosmetically perfect outcome, that they're going to have a full range of motion, that there are no potential complications or sequelae, because there can be. And I think if a patient understands this up front, that we're going to achieve, do our best to give them a perfect outcome, but in fact, we're going to try to optimize the outcome, but it may be less than perfect. Patients need to understand that going in. So again, as Dr. Ganley would point out, if you get a second chance to revise a failed bunion procedure, you better get it right. And the question is, what do you want to do about this? Now, in general, I will say that my own preference, based on literature and experience, has been arthrodesis for revision surgeries. And anything less than that, I think, is whether or not you feel lucky as the person at the other end of Clint Eastwood and his guns would be. So in general, for hallux varus, are there circumstances where I might vary from this? Of course there are. But in general, I know that arthrodesis will fix the problem unless there's a failure to fusion. If there's avascular necrosis or osteoarthritis or arthrofibrosis, will I try various methods to mobilize the joint, soft tissue release and so forth? Yes, I will do that when appropriate, but in general, if the patient is having significant discomfort, significant problems, again, I'll go ahead with a first MPJ fusion. When there is excessive shortening with transfer metatarsalgia, once again, my go-to procedure is going to be arthrodesis with interpositional grafting, sometimes lesser metatarsal osteotomy, but my reasoning on this is as follows. If a person has lesser metatarsal pain because of shortening or insufficiency of the first ray, I feel that when I shorten the adjacent metatarsals, I'm creating additional deformities to compensate for the primary deformity, which is insufficiency of that first ray. Now, with that said, shortening osteotomies of lesser metatarsals for transfer metatarsalgia is very much consistent with the standard of care. But you can only shorten lesser metatarsals to a point. And if you have significant first ray instability, significant shortening, then again I'm going to look to increase weight bearing on that first ray by arthrodesis, whether it's distal or proximal as required. Interpositional grafting, one can consider bone lengthening, bone transport if you think that's appropriate. And I may or may not combine that with lesser metatarsal osteotomies. If there's a recurrence of hallux valgus deformity, once again, I look at the etiology of this. I discuss options for patients. To me, the go-to procedure is going to be either first MPJ arthrodesis or a Lapidus type procedure. And if there's recurrent increased intermetatarsal angulation, once again, if you feel it's appropriate in certain circumstances, it's certainly not wrong to re-osteotomize, to redo soft tissue release, do tendon transfers as you think is appropriate. But to me, the go-to procedure is going to be the Lapidus procedure. If we look at what literature there is to give us guidance for looking at recurrence of bunion deformities, there are not major studies, but again, looking at what's out there, looking at the Lapidus procedure for treatment of recurrent bunion deformities, we see generally satisfactory reported outcome. Here's another study looking at the Lapidus procedure, again, with generally satisfied outcome in patients that had recurrent deformity. But again, are these things perfect? Of course not. So are there surgeon factors? And of course there are. So that while in any bunion procedure there are many correct choices, there are some that are probably wrong. And oftentimes we may see an inadequate or poor surgical technique. Now, again, recurrence of a bunion or failure of a bunion to be adequately corrected by surgery does not imply negligent care. But looking back at some of the factors that we might control, there may have been inadequate medial capsulorrhaphy and capsular repair. There may be inadequate lateral soft tissue release when that is required. There may have been a failure to produce a congruous joint. There may be a poorly performed osteotomy, and there are times when we look at radiographs and indeed it does appear that perhaps the surgeon had a bad day, and there are cases where osteotomies do appear to be poorly performed. There may be inadequate fixation, either selection of fixation or application of that fixation, and there may be ineffective postoperative care, perioperative care. So, do we see issues with, for example, recurrent hallux valgus, persistence of an intermetatarsal angle, adduction of the second toe? Of course we see these problems. So what are the most common complications with distal metaphyseal osteotomies? Again, I think they're well listed by Kalikian in his 1965 text, and again, I would argue that that list really is unchanged even today. But we do see some problems with distal metaphyseal osteotomies. If there's residual or recurrent deformity, I ask myself, what are the most common problems? And assuming that surgical factors in terms of procedure selection and patient selection weren't the greatest issue, then I say, number one, how is the orientation of the osteotomy? Is there first-ray hypermobility, however one wishes to define that? Did the doctor push the indications for the Austin procedure? Perhaps the procedure was not appropriate for that particular patient. Was there a failure to reduce the proximal articular set angle? Was there inadequacy of the soft tissue release, either medially or laterally? Generally, I find it's best to perform the distal metaphyseal osteotomy of the Austin or chevron type perpendicular to the second metatarsal. If we angle that osteotomy incorrectly, going from medial proximal to distal lateral, we get increased lengthening of the first metatarsal. This can result in stiffening of that joint, tightening of those soft tissues. If we do a misoriented osteotomy, again going from proximal medial to distal lateral, we're giving up a 1 millimeter equals 1 degree correction, and we get less correction with the same osteotomy and same displacement, and there is a apparent higher increased risk of recurrent deformity with a malaligned osteotomy. So we try as best we can, unless it's intended to do so, not to willfully lengthen or shorten that osteotomy. So we want to take the time and be very, very careful in how we orient that cut. Now, when we first do these osteotomies, we take off that exostosis, and we want to remember that at the time we do the exostectomy, it's likely there's still an inner metatarsal angle present, so that if we cut the bone perpendicular to the bone with an increased IM angle, we're going to effectively angle that cut inadvertently from proximal medial to distal lateral. We'll get lengthening, we'll lose some of the ability to correct this, we'll be unstable. So I try to make that cut even for removing the exostosis, and I try to minimally remove that exostosis, but we try to make that cut parallel to the second metatarsal, or willfully rotate our hand to make sure that the osteotomy, the chevron osteotomy, is indeed being performed perpendicular to the second metatarsal, so as not to shorten or lengthen the bone, again, unless that is your specific intent. Similarly, we have to be careful not to go from medial dorsal to plantar lateral, or medial plantar to dorsal lateral, because we will inadvertently dorsally displace or plantar flex that osteotomy unless it is your intent to do so. And there may be circumstances where you want to willfully plantar flex that metatarsal or dorsiflex that metatarsal, or lengthen or shorten. And I would say that if that's the case, I would be careful to dictate that in the operating note that you were willfully doing so. Here's a case where the osteotomy was performed going medial proximal to lateral distal, and within 1 month there is a recurrence of the deformity, because recurrence rates are higher with misorientation of these osteotomies. What about first ray hypermobility? How is it defined? And again, we all know this is difficult to define. We have in the literature various descriptions of ways to assess the person with hypermobility of the first ray, but when all is said and done, many people believe firmly that in the presence of severe hypermobility, severe pronation deformity or posterior tibial tendon dysfunction, severe equinus, that distal metaphyseal osteotomies are associated with a higher risk of failure. So one wants to assess patients as best they can for the presence of hypermobility. What about radiographs? When plaintiffs' experts are critical of poor outcomes following bunion surgery, or as subsequent treating doctors just trying to assess the patient, we tend to rely on x-rays. We look at x-rays and we say, oh, I never would have done this procedure under this circumstance or that circumstance. But in fact, at least one study has shown that whether x-rays are weight-bearing or non-weight-bearing, it really did not serve to alter procedure selection in with some surgeons in terms of bunion procedures. And we want to remember that x-rays are not going to dictate the procedure you're going to do. In the old days, for board certification, and Lord knows I sat for that, and I served as a board examiner both for ACFS when that was required for fellowship, and then later for the American Board of Foot and Ankle Surgery, now formerly the American Board of Podiatric Surgery. We would give candidates angles, and we would do this with students. We'd say, okay, here's the IM angle, here's the PASA, here's the DASA, here's the sesamoid position. What procedure would you do? And anyone in clinical practice knows that that decision making is based upon more than x-rays. For example, we know that if you do a Keller procedure, oftentimes a very high intermetatarsal angle will reduce down to an acceptable level. Or with lateral soft tissue release or medial capsulorrhaphy, we get reduction of an intermetatarsal angle. So the mere measurement of a particular angle on an x-ray does not mandate or dictate a particular procedure. What it tells us is, if, for example, you have a high intermetatarsal angle, then generally you're going to want to do something to reduce that angle. But that final angular reduction may depend on a combination of soft tissue release plus your osseous correction. In fact, I would argue that with larger IM angles, the soft tissue release frequently contributes more to the correction than the osteotomy itself. So we can't just rely on x-rays. There's been a lot of talk about first-ray hypermobility now and triplane correction and increased need for the Lapidus procedure, particularly in the presence of hypermobility. But Faber did two studies, a short-term and long-term study, and they looked at the performance of a Hohmann bunionectomy versus a Lapidus bunionectomy in patients who were defined as having hypermobility of the first ray. And he noted that in follow-up examination, there was no difference in outcome, clinically or on x-ray, in patients who had a hypermobile first ray and underwent either a Hohmann procedure or a Lapidus procedure, thereby implying that in patients with hypermobility, distal metaphyseal osteotomies may be very acceptable. In a 10-year follow-up of 101 feet, Faber followed up with these patients and again noted that in patients with, quote, hypermobility of the first ray, there was no difference in outcome 10 years later between those who underwent a distal metaphyseal osteotomy and those that underwent a Lapidus procedure. So that the argument that hypermobility in and of itself mandates a fusion is simply not supported, at least by the Faber study. Now, with that said, I will just say that personally, for what it's worth, if I have a patient in whom I define what I believe to be problematic hypermobility of the first ray, my first choice is going to be a Lapidus procedure. And that doesn't make it right or wrong. It means that I personally tend to be more comfortable performing a Lapidus procedure in the presence of hypermobility together with pronation control. And we know that the Lapidus procedure, like distal metaphyseal osteotomies, does result in some limitation of pronation. Sometimes there's a failure to account for the proximal articular set angle. This has to be addressed in some manner, otherwise we will have a recurrent hallux valgus. In my own experience doing bunion surgery for 40 years, and I realize some people argue there's no entity of a proximal articular set angle. I don't know how they could possibly argue that, because you certainly see that in some patients. We see it in patients that have juvenile bunions where there's been articular adaptation, and clearly the effective articular healthy cartilage is pointing in a lateral direction. So one must either reduce that directly with an osteotomy subchondrally to rotate that cartilage and orient it back in line with the first metatarsal, or doing a Cheater-Akin. And I think it's fair to say that over the years, the so-called Cheater-Akin has been shown to be an effective means to deal with an elevated proximal articular set angle. If the PASA remains high, and this is felt to be the cause of recurrent bunion, then either a proximal phalangeal osteotomy to compensate for that PASA, or a PASA reducing distal metaphyseal osteotomy or arthrodesis would be appropriate. I think many times there's insufficient medial capsulorrhaphy performed, and again, I'm not saying negligent, I'm saying just insufficient corrections obtained. I like a medial approach, and I take a large wedge of attenuated medial capsular and ligamentous structure. By definition, if we have a hallux valgus and a bunion, particularly with a high intermetatarsal angle, these structures have become attenuated and insufficient, and we want to strengthen these by appropriate shortening. And I believe personally that is best done through a medial approach rather than a dorsal approach. We can also shorten up that medial sesamoidal ligament, helping to replace the sesamoids underneath the metatarsal head. So my own personal approach, is illustrated here, is a medial approach, and then I take a good large wedge out of that medial capsule, much larger I think than most people do. I leave the abductor hallucis attachment at the base of the proximal phalanx. This makes for a very strong, good tag in performing repair. So this would be my preferred approach, but in any event, I think it's important to get a good medial capsular approach. As far as lateral release goes, and by the way, this is through a medial approach, and one can easily release the lateral structures as necessary. These, of course, have become insufficient, or rather, and tightened. And the argument is avascular necrosis a concern? Well, in an effort to avoid lateral releases, we've seen a lot of things advocated. This was a use of a suture button technique with, unfortunately, recurrence due to, in part, a failure to obtain appropriate soft tissue releases, and this required revision surgery and became quite complicated. And as you'd imagine, the patient ended up with severe transfer metatarsalgia. Sometimes we see significant shortening, as in this case where unfortunately a patient did develop avascular necrosis in association with an implant arthroplasty, and we do see patients that get avascular necrosis. So this is not something that cannot occur. Is avascular necrosis associated with lateral release? Well, actually, the literature would suggest that the major loss of blood flow occurs with the medial capsulorrhaphy and release rather than the lateral soft tissue release. Here's a good study looking at 64 patients, 82 distal metaphyseals with adductor release, only one case of AVN, which was non-symptomatic in that patient. Most studies generally demonstrate that when you perform an Austin procedure or distal chevron procedure with or without a lateral release, MRI studies, CT scan studies, bone scans show there is some obvious and predictable temporary loss of blood supply to the capital fragment, but it does not translate in any of these studies into significant or clinically significant AVN. Another study looking at 104 patients studied for over 2 years for evidence of AVN without finding any such problems. Another study of 64 osteotomies, again with no reports of AVN. So we know that avascular necrosis is a rare complication associated with the procedure, and when it does occur, we don't know whether it was a result of the osteotomy, whether it was a result of the soft tissue release. This would be purely conjecture by anyone to suggest that a lateral release or medial capsulorrhaphy was the operative factor causing the avascular necrosis. What about malunion? Malunion is a bit more problematic. It can be due to improper osteotomy orientation. It can be the result of poor reduction, so that the initial osteotomy may have been properly performed, but the reduction was poor. The stability may be not reliable, and we may have initial good correction which was lost over time, perhaps due to osteopenia, an injury following surgery, that type of thing, and certainly postoperative care can play a role. But we do see cases where we look at the immediate postoperative x-rays and we say to ourselves, either the fixation was poor or possibly seeing x-rays such as you see here in these various cases, that the doctor should have said, you know, things aren't going quite as well as I anticipated. We've lost our stability, we've lost our fixation. We need to return you to the operating room now, rather than looking at x-rays such as this and saying, well, we're going to do nothing about it. At a minimum, you would look at something like these x-rays and say, I don't know whether the screws missed, whether they're insufficient, but we're going to get you non-weight bearing. We'll put you in a cast. We're going to wait for the bones to heal. Then we'll go back and retrieve the hardware, which may become symptomatic, or if circumstances demand it, go in and re-reduce and refixate. Malunion generally requires a corrective osteotomy. Again, here's a perfect example of a postoperative x-ray, and nothing was done about it in this patient. They went on to an obvious malunion and hallux varus. And in my opinion, in the short term, you want to go ahead and reduce these things early on, refixate them, do what's appropriate. In the long term, I think you have to consider arthrodesis. Excessive shortening of the first metatarsal, again, can be problematic. It can be associated with insufficiency of the hallux itself, with hallux hammer toe and malalignment, transfer metatarsalgia. And again, there's no perfect answer here. I think many people would say, well, go ahead and shorten the adjacent lesser metatarsals. I would argue no. I think we need to do interpositional grafting, achieve more lengthening, and more importantly, weight bearing of that first ray, rather than try to shorten the other metatarsals and create further deformities to compensate for the initial deformity. Arthrofibrosis, limited motion of the first MPJ following bunion surgery, is a known potential complication. Again, I don't know how individuals can look back at these patients and identify particular factors in general that resulted in this poor outcome. Things can happen. So arthrofibrosis can be due to sesamoid adhesions, overly tight capsular corrections. Dorsal incisions, I think, are more likely associated with arthrofibrosis and limited motion than are medial incisions. Excessive scarring and fibrosis can certainly be responsible. This is not uncommon following bunion surgery. It can be associated with early hallux limitus. We've seen a variety of techniques advocated. This was a patient some years ago referred to me. We were told to consider techniques such as arthrodiastasis. My own experience with this has not been great. I no longer look at arthrodiastasis as a primary means to correct post-bunionectomy arthrofibrosis. Again, there's nothing wrong with it, and some patients seem to do okay, but looking at the effort that's required by the surgeon and the patient, I'm not sure that I was overly excited about this. In general, I'll take the patient back to the operating room, anesthetize the toe, inject the patient with steroid and local anesthesia, and manipulate the toe. And again, if you feel a small external fixator is appropriate, by all means, go ahead and do so. My preferred approach for arthrofibrosis is physical therapy, injection therapy, manipulation under anesthesia, and again, less commonly, arthrofibrosis. Sometimes procedures fail because we push the limits. And again, if in the old days, if you looked at an x-ray like this and asked the candidate what they would do, and they said, I would do a distal metaphyseal osteotomy, they would have failed the examination. They would have said, no, it doesn't meet the criteria. Today we know that it's possible. Theoretically, we get 1 degree of translation of the metatarsal head for every 1 millimeter of transposition of the osteotomy. But we've seen increasingly in the literature support for the large displacement Austin bunionectomy. And we see a variety of papers that have been published over the years looking at performance of the Austin bunionectomy for angles that would have been considered inappropriate for the use of an Austin previously. So, for example, here's a nice study of 1,500 Austin-type bunionectomies with lateral release and medial capsulorrhaphy, 4 cases of AVN out of 1,500 procedures. But notice that hallux valgus angles greater than 50 degrees and IM angle greater than 20 degrees were reported as being successfully corrected. Another paper looking at 60 patients, 66 feet, with an average HAV angle between 31 degrees and average IM angle of 12 degrees, loss of correction in about 1 in 5 patients. And the authors did conclude that in their experience, the loss of correction was more likely associated with higher IM angles. Similarly, this particular study, looking again at 106 bunions in 66 patients, 6 years later, these procedures were performed on patients who had larger IM angles, showing that over time there was some deterioration in correction. Conversely, a nice study by Larry Olaf looking at 13 patients who had an average IM angle of 18 degrees with a good outcome, applying the distal metaphyseal osteotomy for high IM angles. Another study by Morawski looking at greater than 50% displacement of the width of the first metatarsal. And again, this would have been considered heresy some years ago. IM angles up to 18 degrees with no dissatisfied patients, no non-unions, 100% radiographic findings. Another study by John Steenstra looking at 38 cases with 40% or greater displacement of the first metatarsal osteotomy, IM angle change achieved about 15 degrees. So that we see lots and lots of supporting papers. Here another one by Long and Associates, 76 chevron osteotomies with soft tissue release, average intermetatarsal angle of 17 degrees, showing that again, no evidence of AVN and good reliability of the Austin. So that we know that one can certainly justify the use of a distal metaphyseal osteotomy, even with a relatively high intermetatarsal angle with soft tissue release and major transposition of the metatarsal, so that it's difficult to define those patients in whom there is, quote, too much pushing of the indication. Lastly, hallux varus. I've always said that there are two types of people, undercorrectors and overcorrectors. So either people have a tendency towards recurrent hallux valgus in the manner in which they practice, or they have a tendency to overcorrect with hallux varus. But all of us have seen other patients, patients come to us from other surgeons, or had our own patients in whom there has been hallux varus. Now, what one does about a hallux varus depends really on the symptomatology, and anyone with experience will tell you there are patients with a hallux varus who are relatively non-symptomatic. They tend to be more flexible deformities, they fit easily in shoes, and really don't create much in the way of problems for the patient other than perhaps cosmesis. On the other hand, we see those patients that over time develop a secondary not only hallux varus but a dorsal contracture and hallux hammertoe, perhaps with submetatarsal 1 pain, particularly when there's progressive rigidity to the deformity. Looking at the literature overall, correction of hallux varus absent fusion is between 60 and 80% effective depending on the particular papers and summaries you look at. The need for revision surgery after even an initial revision surgery is not at all uncommon. There are problems associated with hallux varus revision surgery given the fact that the patient has already undergone an initial procedure. There is some increased incidence of avascular necrosis. Obviously, we could overcorrect the opposite way and create now a hallux valgus and put the patient back into the problem for which they initially sought care. Arthrofibrosis and degenerative joint disease is not at all uncommon. Lesser metatarsalgia and submetatarsal 1 pain not uncommon, and wound healing complications not uncommon. There have been a variety of techniques described for the treatment of hallux varus, and again, as our friend Clint Eastwood would say, do you feel lucky? As for me, unless I feel there is a strong reason to do otherwise, perhaps I can identify an isolated factor here or there, my preference is to go ahead and do a fusion of the joint. Lastly, there is this issue of malpractice. And I want to show you an ad that runs in New York. It's on the internet, and I'm sure these are nice people. And here's the ad they run that state, unfortunately, we see a lot of patients who have gone to other podiatric surgeons in the hopes of a better life, only to wind up in our office asking for revision bunion surgery to correct mistakes made by someone else. I don't think the recurrence of a bunion deformity is a mistake. And I wonder whether these doctors have perfect bunion results. And if not, I wonder if they tell their patients, I made a mistake. Most malpractice cases begin when a patient has a perceived or poor outcome, seek the opinion of a subsequent treating healthcare provider who implies or suggests or overtly states that the former doctor was negligent in their care and, quote, made a mistake. And I would argue that recurrent hallux valgus deformities or complications following bunion surgery typically are not due to mistakes. Can that happen? Yes, but to suggest to the public that a recurrence or complications from a hallux valgus deformity is a mistake, I think is inappropriate. In looking online, we see attorneys, some of whom are both podiatrists and attorneys, advertising for malpractice claims against podiatrists for the fact that they had some complication following surgery. And I think this is inappropriate in many circumstances. So I'm not suggesting that there cannot be negligence associated with bunion surgery. There most certainly can be. I think I've seen some cases myself. But in general, complications following bunion surgery are known potential complications. All bunionectomy procedures have an associated published failure rate. That is a fact. And when you read the articles, it doesn't say these things failed because the doctor performing the procedure was negligent. It means that all bunionectomies have a published failure rate, and bunion failures, surgical failures, do not imply negligence. We want to remember that in any surgical procedure there are sequelae. Stiffness can be a sequela, transfer metatarsalgia can be a sequela. And I think at times it's difficult to draw that line, for example, between how much shortening is acceptable and how much shortening is excessive. Clearly we see examples where there is excess. Procedure failure does not imply a mistake. It does not imply malpractice. All procedures have a failure rate. Mistake is a different set of circumstances. Complications are different. Complications are unintended circumstances that occur in the performance of a procedure that would not have occurred if the procedure had gone as well as planned. All of us have had osteotomies that perhaps have cracked in performance. That's not negligence. It can happen. We can miss with a fixation device. The importance there, of course, is to recognize that. DVT is a complication. And then there's malpractice. And that means that the patient suffered an injury, has symptomatology, and that the way in which the patient was cared for was not representative of what the average doctor would have done under the same or similar circumstances. But we have to be careful when we throw around words like mistake, when we throw around words like malpractice. And the first thing I think you should ask yourself is, could this have happened to me? And whether or not this was in fact explainable. So hopefully you have had the opportunity to listen to this and give some thought to complications in bunion surgery. Thank you for listening to this session of the Center for Podiatric Education.